Okay, it's 12:30, so I'm gonna go ahead and get started. I'm Katie Shelor. I'm the pediatric nurse practitioner at Pediatric Neurology. I'm just giving us a little bit of a headache update, kind of what we're doing, what we've changed, and then some new and upcoming things that we're seeing that might be beneficial in the future that we don't know a lot about yet. But I will go ahead and get started, and I have no disclosures for this presentation. So we're just gonna look at the different headache types and the pathophys just a little bit, just because it'll come into play later when I'm talking about some of the new things that we're looking at. And then we'll look at some acute management options and prophylactic, and then we'll look at the new treatments that we see. So unfortunately, about 60 to 80% of children will experience headaches before adulthood. So this means that they can experience one headache, some will have chronic headaches. The most common type is tension headaches, which we probably all assumed. And then second most prevalent is migraine. I personally feel like I see a lot of mixed headache syndrome. So we're seeing tension headaches with migrainous features or tension headaches, and then sometimes migraine, or sometimes there's an overlap where the tension headache can turn into migraine. Um, I think cluster headaches I don't see very often. I think there is a misconception that cluster headaches mean that these headaches just cluster together, and that is what a cluster headache is. But many times cluster headaches have different qualities, like it's a stabbing quality instead of like that pressure throbbing that you get with tension or migrainous headaches. And then you're going to have those autonomic features. So you'll have like lacrimation or rhinorrhea that also come with cluster headaches. And we treat those a little bit differently. There's some overlap, obviously, with treatments with all of these. And then obviously we always want to rule out any secondary cause of headaches. These are all primary caused headaches. But secondary headaches, we worry about if the headache is progressive and constant. So all of a sudden, one day they started having a headache, and then the headache has not let up. And it's getting progressively worse and worse and worse. Also, so we see a lot of vomiting and nausea with migrainous headaches. If the vomiting is worse than the nausea, that gives cause for concern. So if we're vomiting a lot, the nausea is not so bad, then I definitely want to get that checked out to make sure that there's not anything else structurally that's going on. Posterior headaches by themselves, I don't feel like are as scary, but sometimes, with fever, we can have posterior headaches, which is also a secondary headache. But you obviously don't want to miss anything like a Chiari malformation or a tumor. But any big changes on neuro exam when they come in, you obviously want to take that into consideration when you're looking for secondary causes of headaches. But febrile illnesses, acute injuries, tumors, vascular problems, all those things can cause secondary headaches. And then one of the ones that I see very often that I don't think we bring up enough, but another cause for secondary headaches is medication overuse. So that's when I get someone in and they have had a headache, but they've been using ibuprofen daily or 5 or 6 days out of the week for the last 3 or 4 months. And a lot of times, we take that ibuprofen away for 10 days or so, which is awful for them. But then that headache will get much, much better just because we're not reliant on that medication anymore, right? So we got used to taking that medication, and then the brain expects it. And then when you don't give it to it, then a lot of times you'll create a worse headache. And then what do you do for a worse headache? Then you take more medication. So just have to rule out any other secondary headaches. Okay, pathophysiology of headaches is very confusing, I think, even still to me. There's, several theories of how everything works. And we know that a few things are in play now. So old theories thought, for a long time, we thought it was an inflammatory process, and that was all it is, right? And then we moved on, oh, no, this is a vascular process. It's just vasodilation that's causing these headaches to occur. And we thought maybe this is why triptans are working so well, right? But now the new theory is that now that we're using all these different medicines and we're able to look into this a little bit more, we know, or we think we know, right? Because it's a theory, that it's triggered by the overreactive nerves are triggered. And then what happens is we get a cortical depression spreading. So the brain kind of gets excited for a little bit, and this spreads across the brain. And then there's an area of non-excitement. And so what happens to this is that the spread causes these signals to go to different parts of the brain. So the brainstem, and then it finally gets to the meninges, so the part of the brain that actually hurts. But at the beginning of that cortical depression spreading, sometimes people will experience aura. So this is that first, 30 minutes prior to the headache. Sometimes we'll get visual symptoms, we'll feel dizzy, you feel nauseous before the headache even occurs. And this can be helpful in some ways because this is a good time to take medication if we know that this is going to turn into a bad headache. But so when all of these things are activated, this also activates vasodilation, pro-inflammatory activation. So those things are working together. So headaches can get really nasty. And then those receptors that relay pain, those get involved as well. So then you start feeling the headache. And then we know that there's extra release of substance P, which is a neuropeptide that does different things in your body. And then the calcitonin gene related peptide, so CGRP, is also released, which can cause the inflammation and that vasodilation to be worse. So that'll come into play when we talk about some of the things that are new and upcoming. But very multifaceted and way more complex than we thought in the past. So some of the acute managements that we're doing, I'm primarily going to talk about tension and migrainous headaches because that's what we see most often, and there's a lot of overlap. But it's the primarily the things that we probably already know about. So I'm not doing anything very different in clinic with these at this point. So Tylenol, ibuprofen, especially for our kids that are 6 and younger. That's the only thing that we can really offer them. And then there's some dosage there. I also find that naproxen works really well for some headaches, and there is some studies that support that. There are not a lot of studies just on pediatric headaches in general, just because we don't want to experiment on them. But if the Tylenol and ibuprofen, that's not really doing it, sometimes we'll move on to the naproxen for tension headaches. And then moving on to migraine. So there's a few different tiers, and I always talk about the tiers with the parents, but we talk about trying to stay on tier 1 if we can, right? Tier 1 is going to have our least amount of side effects. And these overlap with the tension headache. So we try to take these at the onset of headache. So before the brain gets very angry and all of those other things start to occur, if we can take these medicines at the onset of headache, which is really hard for some people to wrap their heads around, taking medicine, especially if we're trying to not take medicine that often. But take the Tylenol, take the ibuprofen, or take the naproxen right at the onset. So I always say if we've given Tylenol and ibuprofen a good run, especially if we think these headaches are migrainous, let's move on to the naproxen and see if that does anything else. Sometimes it's really beneficial, especially if we can catch it at the onset, and then sometimes it's not. And if it's not, then we move on to the tier 2, so the triptans. And we know a lot about the triptans, but again, the theory about the vasodilation, and we know that that happens in the brain during migrainous headaches. These help that, so cause vasoconstriction, which can help headaches and kind of calm everything down. But the only medication that is approved for 6 years and up is technically rizatriptan, although we use some of these other ones. I typically start with rizatriptan. I am a low and slower, so I typically start with 2.5 milligrams, even though this says 5 is fine in all of my readings. So we normally do the melts with the rizatriptan, and I think that's really helpful for kids that can't swallow pills. So I like rizatriptan for that. And then we have sumatriptan or Imitrex, which I think most of us are familiar with. For 12 and up, this is approved We can use it in younger kids, but it's 25 milligram tablet or the nasal spray is what is recommended. And then zolmitriptan or Zomig is typically third line, but it comes in a melt or a tablet. The melts, again, are beneficial. A lot of times, insurance companies want you to try the rizatriptan and the sumatriptan before you move on to the Zomig, and I get that question often. And then you can see the medications, we're just increasing dosage when we get up to the 12 to 17 years of age. And then there's also almatriptan, which we don't use very often. But that's also mentioned in the literature that you can use that. And then tier 3 is combinations of medication. So if those triptans didn't work by themselves, sometimes we use triptan and naproxen together, and sometimes they work really, really well in combination. And you can use these together, right? Because one's an anti-inflammatory and the other one has to do with vasoconstriction. So they don't interact with each other negatively typically, but triptans overall, can cause many symptoms. A lot of times I hear that it causes heaviness and it can cause you to feel really sleepy. So if we're avoiding those side effects, then we obviously want to look at analgesics by themselves. But if we're trying to get better coverage, then we can move on to the combination medications. I've used Maxalt and naproxen together with some good results. I feel like Imitrex and naproxen works a little bit better. There is a tablet form of Imitrex and sumatriptan and naproxen that comes together. And then promethazine and a triptan, I lean away from this a little bit just because they can both make kids very, very drowsy. And we're trying to get on with our lives for the most part. So a lot of times they don't like that side effect that it's going to make them drowsy for a while and they're going to have to miss school or miss soccer or whatever they're going to do. So a lot of times they don't want the two of those together. However, if headaches are bad enough and we're not making good progress, sometimes we can consider that. And then here are just some, so for acute management or prophylactic management. So we're avoiding medications with codeine and butalbital and caffeine just because these can cause dependence in some people. I don't love Fioricet for tension headaches or migraine. I think it works for a little while. And then I feel like we may or may not get great benefit from it after that. And then I was just doing a little research, but there's no big evidence, just because I get this question a lot, that daith piercings really give any additional benefit. I have some patients that have it and swear that they have helped their migraine so much. There's not a lot of literature that backs that up, but hey, if it helps them and they want to go get that done in their own time, I'm not going to discourage that. All right, and then prophylactic management. So the biggest thing that I would love for all of my patients to do is follow their lifestyle modifications that I give them, right? I tell them that we need to make the brain as happy as possible. So these things are important just because it can cause those overactive nerves to be not so overactive. And I always say the brain less angry to my patients. But maintaining adequate hydration, eating regularly, not skipping meals is the big one that I talk about. If your body has to go looking for glucose and it has to do extra work to do anything, gets mad about that, and then you're more at risk for headaches. And then sleeping adequate amounts on a normal schedule. This is really important. Just because I feel like teenagers, especially sometimes younger kids, in the summer, we get all out of whack. They're going to bed at 3 a.m. and they're not waking up until noon. And then maybe the next night they're doing something different. Sometimes they can see an increase in headaches when our sleep schedule is really messed up. And it doesn't allow your body to get into those good deep sleeps. And that's when you do your best brain healing. But I tell them to make sure they're on a good schedule, and that will allow them to for their brain to heal and do what it needs to do. Also, I always advise to turn off screens about an hour maybe 2 hours before bedtime. I tell them this because their brain is really smart, but not smart enough to know that this screen that they're looking at is not light from the outside. So your body continues to make higher levels of serotonin instead of melatonin. So when serotonin's up high, melatonin stays low. And I tell them they need to turn off these screens so their body knows to switch. And when we're making higher levels of melatonin, it's actually a good anti-inflammatory for your brain if your brain is making it, not the over-the-counter kind. And melatonin just helps your brain reset. We know that sleep in general helps headaches, so I just really pound this one into them. And they typically, this is the hardest one for all across the board to follow, is to turn off those screens about an hour before bedtime. But I just suggest that they do something quiet, like read a physical book, journal, draw, turn the lights down low. And then I kind of refer way back to, 1823 when the sun went down. Our brains knew that this was the time to make melatonin, and we've really tricked ourselves by sitting in these light boxes and then looking at screens for the last 50, 60 years, 70 years. Oh, how long ago has that been? So also being active outside for at least 15 to 30 minutes daily. I always tell them to go outside for the first 15 minutes without any sunscreen on. Some sunscreens can block how much vitamin D you're absorbing. But low vitamin D, there is some correlation that headaches can be worse or more chronic or more severe if your vitamin D is low. I check this in a lot of my patients. A lot of my patients do end up being low. I've seen as low as 6. And then recently I just had someone, it might have been the highest one, but they were in the 80s and they weren't on supplementation. So I just really ask them to go outside for that long and just absorb some vitamin D. That's your best source of it. And then limiting the use of caffeine and medications for rebound headaches. I talked about rebound headaches earlier, but like the medications, your body can get used to caffeine, and caffeine, your body tends to want after you've had it for so long. So if you have a morning where you forget your coffee, sometimes you'll get a headache from that. So this can also be a headache trigger. So I tell them they either need to surprise their body with caffeine or they need to not change their caffeine intake at all. So you need to have the same amount of caffeine at the same time of day without change ever. And that will help your headaches kind of stay at bay. And if you guys have seen any of my after visit summaries, I put patient instructions on there. This looks awful, actually. It's very blurry, but anyways, it's a little thing that I put on there so they know what they're supposed to be doing when they get home so they can print it off. All right, prophylactic measures that we can do for tension headaches, magnesium, riboflavin, melatonin. There's some correlation that we are low in this kind of across the board. And parents will kind of stick to this, especially that it's like a natural thing that we can do. The side effect profile is pretty low. Magnesium can cause your belly to be upset. Obviously, we want to watch kind of the dosing on those things, but it's typically well tolerated. And we can start with that first. Sometimes we do, and sometimes we don't. I use melatonin sparingly. When I first started out, I used it a little bit more often. But melatonin, if we're not getting good sleep, that can also help with headaches in that manner. Tension headaches, low dose amitriptyline can sometimes help if we have a lot of tension and we know there's a lot of stress and this is causing an increase in tension headaches. Sometimes amitriptyline is a good one to use. Normally, like it says, low dose 5 to 10 milligrams. Normally for, older kids, 10 milligrams we start off with, and then we kind of increase from there. There are some positive correlations with Topamax. Topamax is, I call it the neurology salve, but it kind of calms everything down in the brain, or so we theorize. And then gabapentin, I feel like works a little bit more like amitriptyline. And they're also studying gabapentin for some anxiety disorder, so there might be some correlation with that. Behavioral therapy is never a bad idea, especially if we feel like there's a lot of stress that's causing tension, which is causing tension headaches. And then we also want to look at muscle contraction components with tension headaches. So sometimes we're teeth grinding at night. This is a big one that I see, or we're clenching our jaw during the day. A lot of times I'll just feel in their TMJs. If there's tenderness, it could signify that we have one of those things or both of those things going on at the same time. Sometimes for teeth grinding, the dentist will do a mouth guard, but not always. Sometimes they make them wait until 18. Jaw clenching, I feel like, is an easier one to talk about just because we can do something about that one. I'm very guilty of that. I still do it even though I talk about it all day, every day. But I tell patients to not clench their jaw, do TMJ massages 3 times a day for 1 minute, so not long, but hopefully to loosen things up a little bit. Try to relax their tongue in their mouth and don't stick it very hard to the roof of their mouth. That can cause that same sort of pain, which can cause tension headaches. And then avoiding chewy foods. So if they're chewing gum all the time, they really like taffy, they really like chewy steak, then they need to avoid that. And then the things that we're widely using for migraine, again, it's an overlap with tension headaches, but we can always try magnesium, riboflavin, and melatonin. Again, the thought is that if we're deficient in some of those things, some of the excitability in our brain can be increased, which causes the headaches. For younger kids, cyproheptadine is a really good choice. It comes in a liquid form. The side effect profile is pretty low, can cause sleepiness. So typically I tell parents to give it at night. If we're having issues with appetite or anything like that, sometimes it can increase appetite. We have to watch that in our children that are already overweight. But typically it's fairly well tolerated. It shows you the milligrams per kilogram per day that's recommended. I follow that very loosely. Again, I start low and then increase from there, as with all these other medications. Amitriptyline, again, another one that has shown to have some benefit with migrainous headaches as well, Topamax. And then propranolol is the other one that helps a little bit more migraine than it does in tension headaches. However, if there is some anxiety that's causing tension headaches, propranolol can sometimes decrease anxiety, which also decreases tension headaches. I also try to think about kind of what else is going on that might be contributing to headaches. So if they're having a lot of allergies, cyproheptadine can help with allergies, and it can help with the headaches as well. So if we can kill a couple of birds with one stone, then that's even better. But these are pretty common in what we are using now and what they're still recommending. So I wanted to go into a couple of our new treatment options that I really haven't used that much, but I'm learning about and may be using them in the future. But the first one is Neurivio. It's a remote electrical neuromodulation device. It's a pretty neat one. Just prescribed it for the first time in the last couple of weeks, and 2 people are going to try it out. And I wish I had an update to let you guys know how that was working out for them. But the studies have shown that pain relief at 2 hours, there's 3/4 of them reported that the pain relief was pretty great. The side effects are pretty minimal. And it can be used in place or with medication. It can be used every other day to prevent headaches. It can be used just at the onset of headache. But the thought is that you wear this device on your arm and it sends signals up to your brain, which causes that trigeminal area to not be able to send the pain signals to cause headache. So it's kind of blocking that. And the side effects are some tingling in your arm. And I think that's pretty much it. I've not seen any other big side effects. I think dizziness or nausea were in a couple of studies. But otherwise, people tolerate it really well. And if parents are looking for something that's not medication, I think this is a good alternative. You do have to wear it for 45 minutes at a time. It comes with 18 uses per device. It's unclear how well insurance is going to cover this, so it's a little bit of a question mark. It is approved for 12 and up. And then there are some instances where you can't use it. So if we have a pacemaker or there's uncontrolled epilepsy, it's recommended that you don't use. And then again, you have to replace it after 18 uses. I think the initial device is like $49, and then refills after that are $80 or $89 out of pocket. But here's just a little table kind of showing you what's happening during that. So kind of blocking that pain that is coming from the migraine headache. And again, like any of these things, it works best if you use it at the onset, not when the migraine's been going for hours, but you can use it in the middle. And then the CGRP antagonists. So these are kind of on the horizon. We're just waiting for them. So your Nurtex, your Aimovigs, your Jovies, Ubrelvies, they're not approved for 18 and under. Have difficulty getting them approved for people 18 and under. There are a couple of private insurances that will approve them. The thought is what I was talking about earlier, in the pathophysiology. At some point that CGRP is released, which causes that vasodilation and inflammatory process to kind of continue or worsen. And these CGRP antagonists will stop that or lessen the CGRP that's released, and hopefully stop headaches or lessen them, or lessen the severity of them overall. The side effect profile is really low. Unlike the triptans, it doesn't make you really tired, really heavy, anything like that. I think a couple of my patients that have used the oral form of it have complained of some nausea, but otherwise they do really well. You have to have very specific indications, more like chronic headaches, more than 8 headache days per month. If we're having less than that, then a lot of times the insurance is not going to look at that. They really want you to try 2 of the triptans before you try using one of these. They want them to be within the last 183 days. It's very specific. And then we normally want to use this after puberty, just because there are some things that it could disrupt. So there are some studies that CGRP and how it works, it can decrease the bone health, it can decrease like growth. So we definitely don't want to stunt anyone's growth by using CGRP. So definitely use it later. I don't think I've given it to anyone less than 15. And then it does a lot of cool things with the placenta and how that is formed and how that talks to babies. So we definitely don't want to give it if the patient is pregnant. And I think that is the big thing, but those are kind of on the horizon. And then one of the more exciting things is we may be able to offer Botox in the future at our clinic, hopefully within the next several months. But if there's several prophylactic medications that have failed, this is a good one to use. It's approved for 12 plus, so hopefully we can get it covered in clinic in the next several months when we have our new person coming. And it's overall safe with a low side effect profile. Obviously, you're going to have some injection pain. And there's not been a lot of study on pediatric patients in Botox, but the overall thought is that it should be, in theory, effective like it would in our adult patients, but we know how that is. And then it kind of decreases those the receptor activity where you're giving those injections and that trigeminal area that a lot of times can trigger the cascade of things, which helps prevent headaches and migraines overall.